16th episode of the UFTM podcast. My name is Fabian, and today we are recording from Chicago, Illinois in the United States. And just like in all of our other podcasts, we've been invited to a GP practice, this time by Dr. Jeff Panzer, a GP specialist who has many different special interests. His practice is based a bit outside of Chicago, but he works at two different institutions. He will talk about this at a later stage. He's not from Chicago originally. He's actually from Philadelphia, where he did his undergraduate and postgraduate study, and maybe he'll talk about why he ended up in Ethiopia as a medical director before getting into technology and innovation as a medical director and then setting up his GP practice. A lot of very interesting steps in his life, and I'm very glad, Jeff, that you took the time today to invite us to your practice.
Thanks so much. It's great to be here. Excited for the talk.
Jeff, when I read up about your life and when we started our email conversation, you quickly said, well, I actually work in two different places. Is that a very common thing for GPs to actually do GP practice work and something else?
I think it's pretty common these days for doctors to do practice, their clinical practice, and then some sort of administrative work. So I don't think that's that uncommon, as more GPs are working in health centers or in big institutions to have a clinical practice and then an additional role. I think mine is a little bit unique, working at two different organizations as I started my own practice. So yeah, I think that's probably a little bit more unique.
Americans are very big on abbreviations, and when you emailed me, you said, well, I work at a DPC and an MHN practice. What does that mean?
So DPC is direct primary care, which is an innovative care model that has been gaining speed over the last 10 years. It's been around probably a little bit longer than that, but it's a subscription-based model, and it's low-cost subscription-based model to solve for several problems with our health system, with our delivery system, specifically around primary care. So that's what DPC means, direct primary care. My other role is not as commonly used of an acronym. It's a company, so it's called Medical Home Network, and it's a company that works with health centers. I've spent many years working at health centers, which have, in the U.S., we call them Federally Qualified Health Centers. FQHC is our term for community health centers, and there's government funding and other ways that help support those institutions to take care of more vulnerable populations. So Medical Home Network is an organization that is helping community health centers transition to value-based care payments instead of fee-for-service, which is paying per visit or getting paid per visit by insurance or by a government insurance, getting paid sort of monthly lump sums and then shared savings if you take good care of patients, keep the cost down. That sort of value-based care theoretically allows you to do better primary care. So direct primary care and value-based care through Medical Home Network, they're both trying to take advantage of different payment models that would incentivize you to do the right things to help people with getting better healthcare and having better health outcomes.
Practice that we are sitting in right now, that's your practice, so you set up your own business essentially.
Yeah, that's correct. It's called Bridge Direct Care. I opened it about 1.5 years ago. What I would say about direct primary care is it's a grassroots movement. Doctors who are frustrated with sort of the industrialized model of primary care, where you're employed by a large institution, you have very limited time to see patients, 15-minute visits, and it's just hard to build a relationship and do what you think is in the best interest of your patients. So there's this movement that I mentioned called direct primary care, where doctors have left the institutions and formed their own practices, and so it's bottom-up grassroots movement, and we help each other. So I have friends that have been doing this prior to me, and for free they basically provide free advice, lots of hours of assistance to help me get my practice off the ground. And there's technologies and other facilitators that help people like me start my own practice in an era when doctors' offices are being sort of bought up by the bigger institutions. This sort of model is now emerging as an option for people to start a small practice.
So it's kind of counterbalancing the effect that bigger institutions try to buy up and form big institutions rather than having individualized doctors' own practices. Is that it?
Yeah, I think so. We see it throughout our society. Small business is hard to sustain in many settings. We have larger institutions, coffee shops that get bought up by larger coffee shops. So as larger companies like coffee shops becoming national corporate brands, you see that in healthcare as well. And I think for certain things, for certain aspects of healthcare, take something like transplant surgery. Of course, we want that to be done in huge institutions that have all of the sort of resources exactly that you need large organizations. With something like primary care, it feels like that trend being part of larger organizations has some positives, the connectivity between primary care and specialty care, for example. But there's something that's sort of lost, and I think part of that has to do with the way we measure, like what is good primary care. And in a big organization, you might measure that in a few quality measures that are not bad in and of themselves, but when you reduce what is good primary care to a few quality measures, for example, cervical cancer screening or colon cancer screening or depression screening, those are all, decent quality measures. But if you say, well, this is how good of a doctor I am based off of those, that's, I feel like, is reductionist. And you're actually missing something more fundamental, more foundational that's important, such as, do my patients trust me? Have I built a good relationship with them? Do they have good access? Can they reach out for not just the larger questions for an appointment, but can they get in touch with like, hey doc, I'm having this issue. Do I need to be seen? Like those sort of questions. So that level of like relationship, continuity, access that I think are more foundational are harder to measure. And so it's harder for a large organization to try to aim for those outcomes. So you aim for what you can measure, and oftentimes those are just inadequate to judge what is good primary care. And so I think as a small organization, small business, what you see sort of the benefits of small business, in any industry is you have like the owner of the business really cares about the experience and the total experience. They're not, apologizing, or they would never say, well, that's not my fault, that no, the whole experience for the patient is, if anything goes wrong, you take responsibility for that. And so I think people want that in their primary care. They want a level of service and experience that is good, that is positive. And as a small practice, you can do that in direct primary care because of various factors that are specific to direct primary care that allow you to have the capacity to really serve people in, I think, a better way.
There must have been a really difficult step though to go and decide, okay, I'm actually going to start my own business. And what you talked about now, I think it reminded me a lot of that New England Journal paper that you published a couple of years ago. If you want, we can actually link it in the show notes, and then our listeners can read it if they want. You actually call it the solution shop and the production line concept, I think. Is that a bit what you just mentioned?
Yeah, I think so. The aspects of healthcare that are easier to measure, that are oftentimes processes, like, cancer screening, depression screening,
a checkbox,
etc. They're things that a team can do. They don't have to be the clinician, but a good team-based care, oftentimes it could be done as a team. Those are important, right? We want to have sort of the standardized evidence-based processes being done. I certainly want all my patients who want to get all the evidence-based interventions done. Of course I want them done. I think that because those sort of what we called in our article production line activities are easier to measure.
Production line means the standardized processes like getting everyone vaccinated, getting checkups done on a regular roster or schedule.
I think the examples I would use are immunizations, chronic disease management, making sure your diabetics had their foot exams and their eye exams, all of that. So all of the evidence-based care for prevention, for chronic disease management is done. And I think we, as individuals having interactions human to human, doctor to patient, aren't necessarily good at remembering in the moment to do everything. And so, having systems to do that is great and really important. And I think we've made huge advances over the last 20 years with electronic medical records to help support that. Unfortunately, that same trend with electronic medical records has sort of made it harder for the human side, for having conversations where you ask a lot of open-ended questions and you get to know, what really matters to this patient. What is the most important thing for us to actually be talking about? And then what I talk about in that article is like, I had this real experience where I'm with a patient and talking about all of the evidence-based treatment that they need for their diabetes, and they mentioned that they were dizzy recently. And I noticed in myself this like anxiety build up where like, oh, I don't have enough time, and
So busy with a checklist.
I'm so busy with the checklist. I have too many patients waiting, and I'm like, don't they know I'm trying to help them? Like, why are they interrupting me? But I'm saying that in joke. Of course, the most important thing is that patient's dizzy spell. Like, how could me making sure that they got their foot exam be more important than like addressing a symptom, like a potentially serious symptom? Me and my co-author both are fans of Clayton Christensen, the late Clayton Christensen. He's a sort of innovation guru from Harvard Business School, had wrote a lot about these concepts. And so the solution shop and production line were sort of taken from his theory. And the solution shop is basically a consultant or a lawyer or a doctor, like somebody who has to take a complex problem and like use problem solving skills. And it's very nuanced. It is not as measurable. It's really important for patients because they want to have their problems sort of thought through and help to get to a diagnosis and a potential treatment. That's problem solving. But it's also really important, I think, to not just me, but to a lot of clinicians. I think we get trained to sort of do complex diagnosis, or even if it's not a serious disease, it still sometimes is really hard to take the history and your medical knowledge and come to actually think this is
an idea or like a diagnosis that you might suspect.
Yeah, exactly. I think that my identity as a physician is tied up in that, and I realized that the system doesn't really measure that, or because you're not measuring it, it doesn't really care about that as much, whereas certainly doctors and other clinicians care about it, and patients, of course, care about it. And so that disconnect.
It reminded me a bit of a think tank versus an industrialized process where you have a workshop that you need to make more efficient. And I found it a very good comparison of the struggles that most of our young GPs and also the specialists struggle with every day, because they want to focus more on the innovation, on the think tank, but they're actually stuck in the assembly line. I found that a very, very good image. When you published this paper, you were actually in a different role. You weren't settled down in your own GP practice, but you were a medical director in a public health institution, or I guess it was a company, but it was also a tech innovation role that you had. What made you go out of clinical medicine and go into this medical director role where you looked at healthcare from the other side?
Yeah, so I've always practiced throughout I finished residency in Philadelphia in 2009, so I guess it's been 16 years. Worked in Ethiopia for a year and then came to Chicago area where my wife's family's from, and have practiced throughout. The job that I had when I wrote that article a few years ago was I was working at one of those community health centers that we called federally qualified health centers. Right. It is called Tapestry 360 Health in Chicago, and it's a great institution and do great things and provide great care to vulnerable populations on the north side of Chicago. A lot of immigrant populations and people with serious mental illness, and it's really good work. I was also working at an organization called Alliance Chicago, which is sort of a network of a lot of community health centers, and they help support a lot of the technology. So you're right, they help support a lot of the technology at these health centers. It's sort of like economies of scale. Rather than all the health centers having to purchase an electronic medical record, they sort of would facilitate that. And so they had a design team and an informatics team, and I worked closely with them. And over the years, I've been very interested in design. I went to a grad school program in Northwestern called...
It's up here in Chicago, right? Or close?
Yeah, it's in Chicago. And the program was a Master's of Science in Healthcare Quality and Patient Safety. Wow. Really interesting program. Healthcare quality, learning all about engineering principles that came from Toyota Production System out of the engineering world into healthcare. There's an organization called the Institute for Healthcare Improvement out of Cambridge in Massachusetts. They have a global footprint. It's a great organization to learn about internationally. And then patient safety was a lot about design. How do we design systems to prevent what is going to, we as humans, to err as human, we're going to make mistakes. If you do an activity repetitively and 90% of the time you do it right and 10% of the time you do it wrong, is that even an error, or is that just probability? We call that an error, but really that's known probability. So how do we design our systems to be safer so that when that 10% happens, it doesn't actually touch patients? Primary care is a lot of cognitive work, information hazard. So for me, my translation of the patient safety classes I took was really about information hazard and how do we design technology to make it easier for us to get the information that we need at the right time at the right place. So I got really interested in design and in informatics. So I was able to, throughout several years, I worked, I guess, as sort of a systems designer. I started an innovation center at Tapestry where we had a clinic that was one of our operating clinics. We basically said, we're going to get permission at this one site to sort of separate ourselves operationally from the rest of the clinics and be able to test different team-based care models. And then also technology, we were able to test different technologies and changes to the technology at that center, sort of looking at care delivery as a whole. And I was able to facilitate that by working at both organizations.
So you were essentially a bit of clinical work, but then you'd go back to the office and come up with an idea of how to set up a system or an information model, and then you go and try it out in practice?
Exactly.
Oh, that's pretty cool. It's a very good setup, having both worlds in 1 week, I guess.
Yeah, it's great. We worked on a technology to help with care gap closure for chronic disease and preventive care, immunizations and screening questions and cancer screening. We were actually able to put into production the technology just at our one center, test it with real clinicians and real patients in a safe way, and iterate on it multiple times, 12 times in a year. So every month we changed it until we got it better and better. So that level of sort of iteration doesn't often happen in healthcare, where it happens, much more frequently than once a month in places like Google or Apple, where there are way more iterations to make their products a lot better. So it was fun.
What was your work-life balance like during that time? Sounds, because Google and Facebook, yes, they have a very nice workplace, but it sounds like also a lot of hard work.
I have 3 kids, and they're now 13, 11, and almost 8. And I coach a lot of youth sports teams. And so, balance. I don't call it work-life balance. I just call it life balance. I had a teacher once that was like, you're still living while you're at work. I I get a lot of meaning from my work. And so how do you look at total hours in a week?
That's a good word, life balance.
Life balance. I have this many hours in a week. How do I divvy up my time and make sure that I'm not putting too much into the work bucket? That I'm also have the kid, spending time with my family, and then also, fun and exercise and all of the other things that are important, sleep. But I think for me, having 2 different jobs, and even my current 2 different jobs, they are definitely related enough that it feels like they complement each other. But I will say the challenge of having 2 jobs is always going to be the multitasking, having 2 different emails. And one thing I've learned in my information hazard studying patient safety is how bad multitasking is for our brains, and the ability to sort of monotask and not jump between different things. I've learned over the years, and I think that's a really important for me as an individual with 2 different jobs. Is Monday, Wednesday, Friday I'm in my clinic, and Tuesday, Thursday I work at Medical Home Network. I'm not checking email for the other job while I'm at the other job. It's really important for me to be really focused. I've learned that over the years. When I started working, I thought multitasking was like a sign of strength or something like that. I don't think that anymore.
I think that's a very important learning as well. I think lots of our younger generation struggles with the idea of having to multitask all the time, especially when you look at healthcare. People expect you to publish, to do innovative work, to see patients, and I think that's very common to have that multitask strain on you.
Yeah.
And that takes a lot out of your work life or life balance, as you say. Yeah, that's a very important point. One of the things that you did mention was your time in Ethiopia, and I think that's something very unusual, especially for someone who studied in the US. How come you decided to go to Ethiopia?
Yeah, so when I was in medical school, this is in the early 2000s, there was a physician, anthropologist named Paul Farmer, who was popular amongst his theory. His books and his speeches were very popular among medical students in the US. And he had set up a clinic, institution in Haiti and then elsewhere around the world. And he wrote a book called Pathologies of Power and Infections and Inequalities, and just looking at the social inequities in society and how that drives poor health outcomes. I was influenced by his work, and you don't have to go very far in the US, in many cities, and you can see huge inequities. But I had spent some time working abroad in medical school and residency, and my wife and I, she works in public health, and we had an opportunity to move abroad to Ethiopia, and I wanted to do service work and have that experience and see where it went. So yeah, that was part of my motivation. Once I was in medical school, I thought of healthcare as a means for doing social justice work and put myself in a place where I could learn and potentially help. And I say that I learned a lot doing development work. Once I was in Ethiopia, I was working in a rural health center. It was sort of a mom and pop NGO. Speaking of small businesses, they operated 2 different clinics, one in Kenya and one in Ethiopia, and very rural, not, they had a lot of funding from a base of funders that they had in Colorado, and they had been there for many decades. So it was well sort of established in the communities they were in, and there was a few expats, like myself and my wife, working there, but mostly Ethiopians, and it was really like ingrained in the community there. And I thought when I was there, the challenges would be like the tropical diseases that I don't care for in the US, like tetanus and tuberculosis and typhoid, all of the T's. And those were hard. I learned how to care for new diseases, but I also learned about systems and incentives, and a lot of our nurses would get financial incentives to leave clinic, and it was hard for us to sort of staff the clinic, and we're sort of puzzled at like, why is this happening? And you realize that there's a lot of like funding that's coming that's measuring how many trainings you had done or how many nurses have we trained for HIV care and other diseases. And you realize, oh wow, like these big institutions that are well-meaning are sort of disrupting like what the local community probably needs. And I think we recognized we weren't native Ethiopians, and we always have our own biases, and we were really careful to like not overstate our opinions on like what should be done. There's cultural components, but it was interesting being part of a small organization in another country and learning that, like, seeing the larger institutions and how they influenced our local setting. And I think I'm mentioning that now in this way because fast forward to now, I see these large institutions that are sort of incentives are to see as many patients as you can.
Production line.
To make sure that you're, yeah, exactly. What I learned there was about systems, like how to, think about systems and also do quality improvement work before I really knew what that was. And we were doing a lot of, why are we doing the process this way? And how can we do tests of change and change it? So working in Ethiopia was a great experience. And I mean, the people there are amazing and I miss it. And I went back on 2 occasions to try to do some short-term projects, but it's hard to sustain with a family.
Did you have your children when you were in Ethiopia, or was it beforehand?
That was before. So we started having kids like immediately when we came back.
You came back, yeah. You decided not to go back to Philadelphia, but then to come to Chicago. Was that because of your family as well?
Yeah, so my wife's family is, we have a great network here. We're in Evanston, you mentioned before. I'm just north of Chicago. We're along Lake Michigan is the huge body of water here. And so we're along Lake Michigan. There's a big university called Northwestern here.
Where you did your master's as well.
Yeah, exactly. And so my kids have 8 cousins in the neighborhood, and it's great. And actually my clinic that we're sitting in right now is 2 blocks from my house. So
perfect. You can bike to work.
I can walk to work. I used to bike to my clinic in Chicago that I was working at up until recently. 45-minute bike ride, 9 miles, which is a nice ride, but a little bit more treacherous than 2-block walk.
Very nice. Jeff, we have a game that we play in this podcast. It's adapted from a German podcast, and it's called an A and B game. You might have heard of it or listened to one of the other podcasts where we play it. Well, we always give you word pairs. The idea is to answer as quickly as possible. Don't think too much about what the right answer is. There's no right or wrong answer. What comes to mind first is probably the best answer. And if you really don't know, you can always say skip. And if there is a word pair that you want to circle back to, we can always go and have a look at a word afterwards. Are you ready?
I'm ready. Let's do it.
Okay. Philadelphia or Chicago?
Chicago.
Ethiopia or the US?
Ethiopia.
Public health or primary care?
Primary care.
Primary care or family medicine?
Family medicine.
Family medicine or healthcare transformation?
Healthcare transformation.
Academia or GP work?
GP work.
Medical director of care integration and innovation or family physician at Bridge Direct Care?
Family physician at Bridge Direct Care.
Salaried or self-employed?
Self-employed.
Production line or solution shop?
Solution shop.
Direct primary care or medical home network?
Direct primary care.
Medical director or GP?
Medical director.
Alliance Chicago or Tapestry 360 Health?
Alliance Chicago.
Temple University or Northwestern University?
Northwestern.
Neuroscience or family medicine?
Family medicine.
Keeping busy or taking time?
Taking time.
Morning or afternoon clinics?
Morning.
Acute or chronic care?
Chronic.
Communicable or non-communicable diseases?
Non-communicable.
Making a diagnosis or initiating treatment?
Making a diagnosis.
Education or clinical practice?
Clinical practice.
Research or clinical practice?
Clinical practice.
Public health innovation or clinical practice?
Public health innovation.
Tech diagnostics or hands-on medicine?
Hands-on medicine.
AI in healthcare or writing notes?
AI in healthcare.
Tech-driven primary care or relationship-centered primary care?
Relationship-centered primary care.
Global health or individual health?
Individual health.
Public health or individual health?
Individual health.
Patient safety or patient care?
Patient care.
Early bird or night owl?
Early bird.
Early bird. Biking or driving?
Biking.
Biking or taking the train?
Biking.
Train or plane?
Train.
City or suburb?
City.
City or countryside?
Countryside.
Starbucks or small coffee roasters?
Small coffee roasters.
Coffee or tea?
Coffee.
Espresso or coffee with milk?
Coffee with milk.
Morning workout or sleeping in?
Morning workout.
Spontaneous or well planned?
Spontaneous.
Working holiday or holiday work?
Holiday work.
Digital detox or always online?
Digital detox.
Chicago deep dish pizza or New York style pizza?
Chicago deep dish.
Lake Michigan sunrise or Chicago skyline at night?
Lake Michigan sunrise.
Amharic or English?
Amharic.
English or Spanish?
Spanish.
Beach volleyball or mountain biking?
Beach volleyball.
Time off or time on?
Time off.
Family or work?
Family.
Success or financial freedom?
Success.
Happiness or success?
Happiness.
Well-being or success?
Well-being.
That was it. 52 word pairs. Thank you so much.
Nice.
Were there any word pairs that you wanted to talk about?
It was really hard for me to answer when the questions that had to do with like clinical practice and other things because they're so tied for me. I think I've been really like fortunate to be put in situations both with graduate school and then beyond to become an amateur clinician designer, I guess I like to say. I'm not just giving user feedback to a technologist to go build something, I'm helping to build it. And so that my identity is really tied up in that. But I'm also a clinician and like the work to sort of build a better system, you have to be a clinician. My identity is tied up in both. And so when you said research versus clinical practice, I never considered myself a researcher, but I've published, 6 or 8 publications that I care deeply about, like the work we're creating with my colleagues at Alliance Chicago, because we're doing sort of innovation research. I would say the questions we're asking are a little bit more nuanced. And like, could there be too much depression screening? Like, who's asking that question? I think research is important, but I guess I consider myself a clinician who likes system innovation, and so they're tied up together.
Pretty much everything circles around your practice and goes into innovation, goes into research, goes into education, patient education, university education. I think you've actually gone quite a long way and ended up with a very sweet spot where you have all your special interests lined up around your work week. I think that's very special and also very inspiring for many of our younger listeners.
Yeah, no, it's great.
Thanks, Jeff, for being on this podcast, and thanks for taking the time today. Is there anything that you would like to share with your younger self if you look back? Is there anything where you say, if I'd known this would have helped me through these struggles and making all these hard decisions?
I don't think I would do things differently. I've made a lot of career changes. I've worked for 4 years at a health center, and then I worked in 2 different organizations that were doing value-based care. And I learned a lot through those, and then I came back to the health center space for 7 years. And I think that I learned a lot through a lot of those transitions. It's hard for me to say I would do anything differently. With that said, I think there's an irony in being a huge advocate for relationship-centered primary care and moving clinics and moving jobs because you're sort of breaking relationships. And so I think if I were starting right now, I would advise at least people in the US to consider something like direct primary care, and because I think that it is meeting patient needs in a way that I feel like is what patients need, and clinicians, we talked before we started the podcast about well-being and for clinicians, and I think that if you truly feel well, then you're able to give so much more to your patients. And I think that it's a solution that could be spread well beyond where it currently is. I think, if it's okay, can I comment a little bit about, so direct primary care has sometimes been thought of as a solution that is not spreadable across our system because it's smaller patient panels. So instead of 1,500 patients, you have 500 patients. And so that would create a crisis of primary care, having enough clinicians to care for our population. The trend that I see of so many people leaving clinical practice or going part-time, I think is worrying. And when I look at this and go to the conferences for direct primary care, and the excitement, the energy around building relationships with patients is pulling, there's ER doctors that are going into primary care because it's so meaningful. I know at least 2 that have taken that route. And so I think long-term, figuring out what is primary care, what is valuable about primary care to patients, to clinicians, and then focusing on how do we do that well. In the US, we use the concept of the 4 C's. It comes from a woman named Barbara Starfield, who's in the 90s, and she sort of solidified to define what we mean by primary care. And the 4 C's are first contact. So if you have a need, you reach out to your primary care doctor first. Comprehensive, you can talk about anything, even dental issues. Even though you're not a dentist, people come to you with teeth concerns. Coordinated, so you're coordinating their care. And then, of course, continuity. And for the first time in a long time, I feel like I'm doing the 4 C's, and it feels really good. And I'm talking to specialists, and I have the time and bandwidth to do that. So coordinating care with specialists. I spend an hour and a half with my new patient visits and really get to know them. And so individuals are paying for the service. For my clinic, it's $85 a month, but I have patients from sort of all walks of life, and now small businesses are starting to. In the US, we have employer-based insurance. So instead of employers spending so much on insurance that's really best positioned for the unexpected, they're actually spending less on insurance and then just contracting directly with a primary care doctor like myself so that they can get, and it's much more affordable because there's not all those added costs of all those middlemen in the system. And so, yeah, you're able to provide a service that I wasn't able to provide in the sort of larger institutions. So I'm excited to see where it goes, and I'm hopeful that my work at Medical Home Network, we can help sort of take some of these things I'm learning here and spread it to the community health center world as well.
Wonderful. Thank you so much, Jeff. I think you've shared very nice insights. I really enjoyed your thoughts about the life balance rather than the work-life balance, and the 4 C's, I think, is a core value that people should look out for when they choose their career path. I think that's very valuable insight. That's gold. Thank you so much, Jeff. Thanks for being on our podcast today. I hope you had fun, and we'll let you get back to your busy practice life. Thanks.
Thanks so much. I appreciate it. It's been great to be here with you today.